Good afternoon. Osstem meeting 2022 live surgery. I'm going to lead this live surgery. I'm Dr. Hyunjun Chung. Thank you for inviting me, and I would like to thank the chair of the session, Kyung-won Kim. In this live surgery, I'm going to talk about all-on-X surgery. First, the patient information and treatment plan. The patient is a 58-year-old male. He has underlying disease hypertension. To control it, aspirin is what he takes. After confirming that there is no medical problem, the drug was stopped from 3 days prior to the surgery. Dental history includes he lost many teeth due to periodontitis. Pre-op portrait without wearing a denture. The lip support is not bad. So this is the intraoral photos pre-op. The remaining teeth in the mandible were extracted on 27th of April due to mobility and others. This is panorama, pre-op panorama. The patient did not use denture before. Dental digital system is used to make a treatment denture using digital approach to stabilize the mandibular position. If the denture fits, that would be scanned and it would be reversed to fabricate a guide. First, the impression needs to be taken. The Denka system has stylus pins in the stock tray. Using Gothic arch concept, the patient's VD and mandibular position can be set. The data is digitalized, so digital denture is designed. After the design, the surgeon approves it, and the try-in denture is used to check occlusion and adaptation. After try-in the portrait, compared to before using denture, lip support is improved, as evidenced by the portrait of the patient encephalo. Using the try-in denture to make a guide, tried-in denture will be scanned and reversed. The stability of the try-in denture is directly linked to the stability of a guide. So we need to pay extra attention to that. So this is the treatment plan for today. On the maxilla, 6 implants in parallel, and in the mandible, 4 implants including 2 tilted implants will be placed. For this, OneGuide design is done. OneGuide reports of maxilla and mandible are cropped and prepared. You may ask, can we place implants in the lower posterior region? Especially at number 36, the residual bone and the thickness of the soft tissue over the alveolar bone is analyzed here. In the implant studio, 6 and 7 millimeter short implants are virtually placed, and they're too close to the inferior alveolar nerve, invading the safe space of 2 millimeter zone. At number 47, the soft tissue thickness and the bone above the inferior alveolar nerve are not sufficient. So, in the interforaminal space, bone is hard and sufficient, but the bone gets less and less toward the posterior region. For a full arch case in mandible, a guided surgery is to be used. To fix the guide, if strong force is applied, soft tissue on the lower posterior will be pressed down. The risk would be increased in this case. First, in a similar case like this, I place the implants in the safe area, the interforaminal space. Later, if the patient gets ready economically and physically, implants will be placed using a guide in the lower posterior region. Vertical bone augmentation and the soft tissue graft can be done. This way, more challenging procedures can be performed with predictability. So that is possible because of Osstem multi-tie base. The tie base uses the library. So over the multi-abutments or multi-angled abutments can be connected, and temporary prosthesis can be designed and milled. So that's all thanks to this multi-tie base of Osstem. So multi-abutment will be connected, and tie base will use as an intermediary. And I will check a prosthetic adaptation if it is appropriate. The tie base will be cemented to the pre-milled temporary. So today's treatment plan summary. First, implant will be placed with OneGuide system. Mandible first, and multi-abutments will be connected. Multi-angled abutments will be connected, and TI base will be connected, and temporary prosthesis adaptation will be checked. In both jaws, adaptation will be checked, and the vertical dimension, mandibular position, and occlusal plane will be checked again. So if in the mandible or maxilla, the primary stability is not achieved, during the osseointegration, treatment denture needs to be used. So because of that, from the design stage, I prepare the guide and provisional prosthesis. So the treatment denture and the temporary prosthesis prepared today can be used without distorting the occlusal plane. So in today's live surgery, we are going to look at the accuracy of Osstem OneGuide system. Second, the temporary denture selection depending on the primary stability and occlusal plane of temporary prosthesis. And the convenience of a digital approach will be explained. Now let's get started with the live surgery.
네.
OneGuide system, full arch restoration, and immediate loading.
네.
Have you checked? 3:25 p.m. We will now begin live surgery.
자, 저는 오늘 이 라이브 서저리를 위해서
For live surgery, I'm going to prepare all-on access system. I'm going to start with lower. Guide is not connected. Tissue punch is done.
이용해서 인덴테이션을 줍니다.
I'm going to make indentation using tissue punch. By purpose, before you placing anchor pin, position is being checked. In the AM, as Dr. Park has mentioned, in order to fixate the implanted template, tissue punch is made to find the position and gingiva is being removed. So if it is in between mucosa, you don't need to pull with strength, but you just need to use the blade to remove it. Tissue have all been removed. Guide will be adapted. Anchor drill is going to be used to firmly fixate the template. Lateral anchor is used. Lateral anchor will be placed and preparations are being done.
앵커 스크루를 고정하겠습니다.
Anchor screw is now going to be fixated.
약 80% 정도의 깊이를
About 80%.
정중에 있는 가운데 있는 앵커를 가장 먼저 고정하셨고.
So he placed the one in the middle very first.
3점에서 고정하고
라테럴 앵커를 고정하실 때
Lateral anchor, when you fixate it,
한쪽에 뭐 치우치지 않도록
you make sure it's not tilted.
약 80% 정도 엔진.
So 80% it's being placed using engine.
나머지를 다시
나머지를
고정하고.
고정하면 됩니다. 아프시지 않으시죠?
Are you in pain?
아무래도 완전 무치약이기 때문에
Because it's fully
가이드 고정이
edentulous,
가장 중요할 것 같습니다.
guide fixation is the key.
우리 박창준
As
교수님
Dr.
얘기했듯이 흔들리지 않는
Professor Chung Ju-bak has mentioned,
템플레이트가 돼야만 저희들이
the template shouldn't move
정확하게 신입이 가능합니다.
to provide accurate implants.
가이드를 견고하게
Guide is firmly fixated.
플래팅들을 이용해서
Flattening drill is going to be used to make the bone
바이올로직 위스를
flat and secure. I'm going to secure biological width.
확정하겠습니다.
저희가 계획한 것이 조금 깊게 진입하기
So we're
때문에
planning to place implants slightly deeply, and flattening drill is used to flatten the alveolar bone.
앞쪽에 42번과 32번
Number 42 and 32.
보면 임플란트의 정확한 신입을 위해서
For accurate placement, flattening drill is used to
하셔야 우리가 원하는
remove the
그리고 미끄러지지
lumps
않게
to prevent the slipping.
예, 술자로서 제가 생각하기에
As a surgeon, Osstem OneGuide kit, among the different components, flattening drill has clinical meaning in that it's very useful. It has most clinical meaning because
임플란트의 장기 유지를 위한
to maintain the implant
그 부분을 우리에게
tools,
제공해줌과 동시에
using the tool you can get the biologic width to fixate it and you can make the bone flat.
드릴이 미끄러지지 않겠죠.
The drill will not slip.
임상적으로
Clinically, I believe it's very meaningful.
이니셜 드릴을 시행하시면
Initial drilling is done
뼈에 하악이기 때문에
because it's lower.
실은 오늘 초기 고정을
Primary
확보하는 부분이
stability
중요하기 때문에
is very important today and it's lower.
일단은 소프트 전용 이니셜 드릴을 한번 사용해 보고 있습니다. 제가
I'm
지금
going to
이
use initial
이니셜 드릴 사용할
drill.
때 느끼는 점은
My impression is that in the lower posterior,
임플란트를 계획하고 있는데요. 실제로 골질이
the bone quality
전치부에 비해서
is compared with anterior, it's weaker.
이니셜 드릴 중에 갖고 있습니다.
That's the impression I get when I'm doing initial drill.
특히 45번 쪽이
In number 45, it's especially so.
앞에 소프트용 이니셜 드릴 썼고 지금 아마
So
3.5mm
soft initial drill for soft is used. Initial drilling is done in 4 areas. In lower anterior,
12번 및
number 32 and 42.
디자인된 자리를
In the designed area,
패스 드릴을 포함한
path drill is done.
프레이션 하고자 합니다.
Prep work is being done.
사용하고 있는 드릴은
The drill that I'm using
3.5직
is 3.5 by 8.5 OneGuide drill.
그다음 4.0에 뭔가 이제 보겠고요.
And next, he's using 4.0 by 8.5.
환자분 조금만 긴장을 풀어주세요.
Please relax a little bit.
사실 저희가 원가이드 이와 같이 라이브 서저리 시행할
When you do
때는
live surgery,
그 어시스트와 술자도 중요하지만
assistant and the surgeon is important, but cooperation from patient is very important.
굉장히 잘 도와주셔서
The patient is really very cooperative.
계획된 시술을 잘 보여드릴 수 있는 것
So I'm able to show you what I've prepared.
32권에
In number 32, implant is being placed.
가지고 약 80% 내외
It's being placed approximately 80%, and fixture driver is used to place it 100%.
하악의 전치 부분
It's lower anterior number 32, and number 42,
파이널 깊이까지 조절해서
it is adjusted up to the final depths.
깊이와 이
Depths.
노란선을 정렬하는 것에 주의하고
So you need to pay attention to the yellow line.
지금 제가 사용하는
In terms of depths, I'm using implant anchor,
버티컬 앵커
vertical anchor system.
임플란트 앵커를 2개 정도
So I'm going to additionally use a vertical anchor to place tilted implant in the posterior area,
후방 볼이 상대적으로 부족한 후방으로 침하되지 않도록
so that the implant does not sink down in the posterior area where it's lacking bone.
픽처 앵커를 이용해서
Fixture anchor is used,
하시고
vertical anchor is used
데코레이션을 시행하죠.
to prep the posterior sites.
지금 사용한 것은
What I'm using right now is a 7mm.
괜찮으세요?
Are you okay?
7mm 길이의
7 by
드릴입니다.
7mm path drill. In number 35,
창이었기 때문에
it's extraction socket.
패스 드릴을 이용해
Path drill is used
드릴이 프레퍼레이션 중에
so that the drill does not slip during prep.
예, 아마 오전에 우리 박창희 교수님도 말씀하셨듯이
As Professor Park has mentioned, in order to prevent the drill from slipping, in the case of extraction socket, the path drill needs to be used.
저희들이 원가이드 드릴 자체가 테이프
The OneGuide drill is with taper type.
그 발치와 같은 경우에
In the case of anterior area,
저의 경사면에서는 미끄러지지 않도록
in
패스 드릴을 적
the slope of extraction, you need to pay attention so that the drill does not slip. A primary stability, when you
파이널 드릴을
are
시행하는
when you have doubts,
생략함으로써
you can forego final drill to get the primary stability.
옵션 중에 하나입니다.
That's one of the options we have to get primary stability.
후방 틸트 임플란트 두 개는
The two tilted implant in the posterior, 4.5 by 8.5, TS4 Osstem implants are used.
식립하겠습니다.
예, 그래서 파이널 골즈를 위해서 아까 보니까
For final
가지고
drill,
속도로 한 번 더 본 퀄리티 확인하시고
the placement speed.
제 위치를 들어가고 있습니다.
Two implants are being placed in space. I need to get primary stability, and that is the key for me.
자, 아무래도 하악에는 지금 저희가
Because in the lower,
바로 프로비저널 레스토레이션을 시작할 예정이기 때문에
we are going to provide immediate provisional. If you look over here, it's over 30 Newton. So primary stability today, it's good.
그리고 힘 현상은 때문에 잘 시행하고 있는 것
It's not stuck, so it's going nicely. Can you say I?
이런 기구를 통해서
Using this kind of spoon type of instrument, you can make sure that whether the yellow line and slot is in line.
30N까지
30 Newton centimeter.
잘 나오는 걸 볼 수 있습니다.
총유 고정이
It's flushed with the yellow line. You can see that.
네, 정 원장님 만족할 만한 스테빌리티가
Dr.
나온 것 같아요.
Chung, I think primary stability is good. Thank you. I'm doing my best.
전방부에
On the anterior area for fixation,
임플란트 앵커를
implant anchors, which were used, will be removed.
앵커 스크루를
Anchor screw,
앵커 스크루를 제거하겠습니다.
I'm going to remove them.
정 원장님 제 말씀 들리세요?
예,
Dr. Chung, can you hear me? Yes.
정원장님 제 얘기 들리세요?
Can you hear me? Yes, I can hear you.
예, 라테럴 앵커 스크루.
Lateral anchor screw is being removed.
주세요. 다시 주세요. 다시 주세요. 자, 어버트만 준비해 주세요.
Can you prepare abutment?
인터컴 스위치 잠깐 개선하시겠습니까? 그냥 진행할까요?
Can we proceed?
정원장님 제 얘기 들리세요?
Can you hear me?
네. 인터컴
Yes.
스위치가 안 들린다는.
I think intercom switch they can't hear.
들리시나요?
Can you hear me? Yes.
조금 인터컴에 문제가 있었던 것 같아요.
I think we had a bit of a technical glitch. Multi-unit abutment is being connected.
들리시나요?
예, 들립니다.
이게 자꾸
Can you hear me?
현상이 있는 것 같습니다. 조심하겠습니다.
So we'll pay more attention with the technical stuff.
지부에 있는 툴팅 쪽은
The tilted implant in the posterior area.
노출돼 있을 수도 있고
Bone may be exposed, therefore abutment it may not be easy to put the abutment. I'm going to form a mini flap to check the bone.
네, 이쪽은 지금 이게
On this side, it's extraction socket,
시원하게 한 번에 쑥 열리지 않고
so it does not open as nicely.
예, 아마 위에 걸리는 돌 조직을 약간 플랫팅 하시는.
So flattening drill is used.
정원장님 지금 임플란트의 뒤쪽에 있는 뼈를 삭제하시는 거죠?
Are you removing bone distal to implant in this
전방도
case?
중요하지만 후방에 있는
Anterior side is important, but the
전방 모두 중요한데
posterior side is also very important. In the posterior side, there is interference.
멀티 앵글드 어버트
Multi-angled abutment is not being connected. Now he's connecting it.
주의해야 되고
You need to be careful
이 부분이
in this area.
좀 이번 수술에서
So this is the most tricky area out of the entire surgery.
손잡이 부분을 해서 될것 같아요.
Handle is removed.
네, 30번 때는 좀
In number 30,
어버트먼트가 체결하셨고
abutment is connected, and in number 40,
조그맣게 플랩을 형성해서
mini flap is formed
시키고
to expose it slightly.
석션. 잘 잡아주십시오.
Please hold.
식립된 임플란트의 디스탈 부위에
Distal to the placed implant.
착지하고 있습니다.
It's being prepped.
네. V 석션 해주세요. 석션. 빼주세요.
Please remove it. I cannot really see.
앵글도 어버트먼트 체결을
Angled abutment is connected.
석션 부탁드립니다.
Suction, please.
이거 치워주세요.
토크는 30N으로
So torque is 30 Newton. Yes, it's 30 Newton.
TI 베이스 주십시오.
Please give me tie base.
예, 지금 4개의
Four angled abutment, multi-unit abutments are connected.
그 위에 TI 베이스
And on top of it, tie base
공기
is connected.
6mm 높이 헤이트에
6mm height, 5-degree taper.
TI 베이스를 선택하였습니다.
That's the tie base that I chose.
TI 베이스를 체결하고 계십니다.
Tie base is being connected.
우선 플랩을 닫기 전에
Before I close flap,
보철물의 적합을 한번 보겠습니다.
I'm going to check the fit of prosthesis. Tie base is connected and the prefabricated prosthesis is being tried in.
잠깐만 다물어 주시겠습니까?
Can you close slightly? Thank you.
예, 보철물의 적합은 괜찮은 것
The
같습니다.
fit looks okay.
이후에 워시해서
After that, I'm going to wash and increase the set fit, and then I'm going to place it. I'm going to do suture now.
보철물의 적합
우리 시험을 해보셨는데 어떻게 잘 맞는 것
You tried in.
네,
Do you think it fits nicely? Yes.
들어간 것 같습니다.
I believe it has been placed in the planned position.
플란트의 식립 깊이가
The placement depths
했던 위치보다 아주 약간
slightly
깊게 들어갈 때
more so than the planned position. It can go in slightly deeper. In this case,
갭이 생기는 효과가
there can be that gap with the prosthesis.
그 임시 보철물이 잘 들어갈 수 있겠습니다. 그런데
The provisional can go in nicely, but
우리가
in this case,
오론 X 시스템이기 때문에
because it is all on X,
플랜지처럼 약간의 형태가 있기 때문에
there's a bit of a flange
남아 있는
because it's all on
시은에 다
X. It hits the residual gingiva so you can fit
임시 보철물을
accurately. That's the way I designed the provisional.
끝나고
So after all surgery is done,
워시하는 과정에 있어서
in the washing process,
그때는 워시하는 과정에 있어서는 너무 과한 플랜지는 조금
excessive flange will be removed
사용 기간 중에
so that self-cleansing can be done by the patient easily.
음식이 많이 저류하지 않도록
And so that food impaction can be prevented.
조철의 수정 과정 중에 시행할 예정입니다.
Adjustments are going to be made.
쫓아가고 있는데요.
Osstem 2022 Live Surgery. The slogan is a little bit easier digital in day-to-day activities. So if you have a bone loss in the mandible, as was presented before, the implants can be placed in the mandibular posterior, but to provide a vertical step as an initial stage, the OneGuide surgery is being done to place implants. So we try to find an appropriate patient for this indication, and the surgery is smoothly progressing. The guide template we have prepared is going to be connected. I cannot hear the intercom. Can you hear me? Now I can hear it. The guide template is set. So the guide is fixated with the hand on the maxilla, and using a tissue punch, the indentations are made. Once again, the tissues are removed in this process. So using a tissue punch, the tissue is removed. The teeth are not good. So the patient, position is a little bit modified. For better visibility. Now, tissue punch is used to remove tissue, and the template is mounted again. Can you say "ah" for lateral anchor? Can you say "ah" to the maximum? So in the planned positions, the guide is fixated. Do you feel pain? Can you say "ah"? Anchor screw design. It is not to be inserted in a slant way. If it is designed obliquely, the guide can shift while it is being pushed in. Say "ah" please. Open your mouth. It's a lateral anchor, but still without deviation. It is designed in a straight way. Unexpectedly, when anchor screws are coming in and the maxilla, we can estimate the bone quality. The upper posterior bone quality is softer than I thought. The density is low. So when we place implants in the maxilla, we need to check whether primary stability can be obtained. If it is not possible to obtain the primary stability, the patient's old denture is going to be used on the maxilla and in the mandible. Immediate loading will be applied. So that's how we determine the mode of temporaries. So there's some unexpected situations. So we have two options. As I mentioned during the presentation, maxilla, I'm going to use a digital temporary denture. It's going to be used different from mandible, and to use the combination before live surgery. I'm a fan of Dr. Jung-in Bae, and I listened to his presentation carefully. So if you use a treatment denture, and it's a reverse scan and make a guide, the denture, the guide, and the temporary can be made. So combination of prosthetics can be used to maintain, and the occlusal plane would be maintained. So do you feel any pain? Is it painful? So flattening drill is used, and now initial drill. So I need to inject the anesthesia. Patient seems to feel pain. Based on my clinical experience in the upper anterior, there are two reasons for the pain. Sorry about this. First, in the upper anterior, on the buccal side, the anesthetic was not sufficient, and in the incisive canal, the anesthesia was not sufficient. And sometimes the patient feels pain if the anesthesia was not enough. So the area is to be receiving anesthesia injection. So the patient feels pain because it's bleeding, and the patient can feel pain. So I'm using a new long needle.
So once the anesthesia kicks in, it's going to be okay. Relax a little bit. Are you okay? I think the patient is a little bit tense because it was slightly painful. Are you uncomfortable? Please tell me if you're uncomfortable. The drill that you're using, what is the length? 3.5 wide, 7. In doing drilling, 3.5 by 8.5 implant is designed. I think we need more anesthetics. So can you change the placement speed? In the posterior area, 4.5 by 10 millimeter was designed. The bone quality is very soft. Placement mode is used to check. I don't think it's going to be easy to do immediate loading here in the posterior area. There is sinus as well as the inferior border of the nasal cavity, so I'm going to use a size longer drill to prep the site before placement. Number 21. Anesthesia, it's not really being done. I'm going to do it once again. Relax a little bit. Okay. I'm going to place the implant. 4.0 by 8.5. 4.0 by 8.5. Yes, that's right. Final drill is going to be done by 3.5. 4.0 drilling is not going to be done full length. I'm going to stop 2 millimeters before. In 11 and 21s, 4.0 by 8.5 implants are placed. In number 13, 4.5 by 8.5 is going to be placed. So it's being placed with engine about 80%. In number 23, 4.5 by 8.5 implant is going to be placed. Number 5, 4.5 by 10 millimeter is prepared. In the posterior area, bone quality is not very good. Engine is used by about 80%. In number 25, 4.5 by 10 millimeter is being placed. I wish I can get primary stability, but it doesn't look easy. In the anterior area, it's 30 Newton centimeter. From number 11, implant placement depth is being adjusted. Number 21. Number 13. How much is the primary stability? It's 30 Newton centimeter. Number 23. About the 30 Newton centimeter. Four implants in the anterior. Initial stability, primary stability looks good. Number 15, posterior area. I think that's the issue. I think it's about 10 Newton. About 20. In actual clinical practice, I don't prefer immediate loading because in the upper, even if you place a 6 implant, if you can't get the 30 Newton in one area, failure can occur. In number 15, it's barely 30, and in the rest of the area, as planned, immediate loading is going to be done, but when doing a occlusal adjustment, I'm going to make it so that not strong occlusal force is not applied to number 15. I'm going to ask the patient to eat softer food for next couple of months to overcome the situation. Anchor screw is being removed. Surgery is being proceeded very quickly. Implants are all placed. It has taken about 40 minutes. It's remarkable speed. Can you say ah? Anchor screw is being removed. The fact that the anchor screw is being removed very easily means the bone quality is not very good. In the upper, implants have been placed, all 6 of them. Can you remove it, please? Multi-unit abutment is being used. The multi-abutment, there's a product with a white handle and one without. Preferably when you connect it, for convenience, use the one with a white handle. That's what I prefer. In the handle stage, you need to tighten as much to be able to tighten easier using driver. If you do make it too loose, when you tighten using driver, at times it may not tighten as easily. In this stage, the driver, if it hits, is good, but if it doesn't, so I'm going to ask the patient to close slightly. The driver, it looks like you can do hand screw. If you apply torque wrench, at times it can be difficult to apply force. So this is a little bit of challenge for me. You're tightening by 30 Newton? Yes. It's difficult because there's gingiva.
Torque wrench clicks. The number 15 is the area of concern. My gloved hand is contaminated and the metal driver feels slippery, but I prayed a lot last night, so it went pretty well. At number 15, which was worrisome, the initial drill went okay. TI base is connected. The TI base, there are 3 types of TI base from Osstem. Degree 5 and 10 degrees. 10 degree is prefabricated, so it can provide the space a little bit more. So in the maxilla, if the prosthesis cannot be properly connected, the interfering area 4 millimeter height and 10 degree would get rid of the interference. So we can avoid the mistakes in the connection of a prosthesis. Now we use 5 degree ones. I trust OneGuide, so the first try in is 5 degree one as planned. So this is the mandibular prosthesis that we tried it in before. So it is adapted and the maxilla. So it went as planned. Please close your mouth with your molar So it went well for maxilla as well.
살짝만 벌려보세요.
Would you open it a little bit, please? Close your mouth. He's checking the bite. So everything goes as planned, and I want to check it again. Can you close the mouth? Bite is okay. Articulation paper. Dr. Chung, are you satisfied? So the occlusal contacts, not bad. It is contaminated a little bit, but there is mobility in the temporaries. So let me check the detailed occlusion. So number 12, we will relieve the occlusion and cement it. So looks like the surgery was successful. So maxilla and mandible situation is very satisfactory. So it's all finished. Okay. Time is good and surgery went well. So are you going to take time to do prosthesis? So live surgery progressed very well, and we will have Q&A with Dr. Chung and the patient. Post-op facial panorama will be taken.
정말 라이브 서저리가 정말 훌륭하고 정말 계획한 대로 잘 이루어진 것 같습니다.
I can see that live surgery occurred very nicely and successfully. Dr. Chung placed the 6 implants in the upper very calmly and 4 in the lower. Successful surgery has been done. And Dr. Chung is going to come to the hall and we're going to have Q&A. I think a lot of questions are being raised in the chat. I'm conflicted as to choose which question. Dr. Chung, he's going to be here any moment now. There was a quite complicated case, fully edentulous case. Dr. Chung, fine here. Congratulations, hard work. It's very successful, wonderful. It's been placed as planned. A lot of questions are being raised. We are unable to proceed in the auditorium. It's difficult to put up the questions on the screen. Out of the question, ID point. In the case of people with strong masticatory force, if you do all on 4, if one fails, it's very difficult to maintain fixed prosthesis. In this case, how would you be able to respond? It's a very difficult question.
So when I design full arch fixed type prosthesis, clinically, I can think of 2 scenarios. The first one is, like in this case, immediate loading is done, and the patient should eat soft food, but he doesn't do that, so a couple of them can fall off, and during usage, biological or mechanical complication can occur, so a couple of them can fall off. In that case, 4 or 6 implants should remain in the mouth. Otherwise, it's not possible to have the fixed type. So if a couple of them fall off, one or, if possible, two more implants need to be placed so that the fixed prosthesis can be maintained with the appropriate number of implants. In the maxilla, there is a leeway, but in the mandible, if one fell off because of bone resorption, there's no way to additionally place an implant, so overdenture or others need to be done. In Korea, the musculatory force is stronger than other countries, all on four. So it is rather challenging in Korea compared to other countries. That's why the question came up. So when we do all on four, we can be faced with such problems. Dr. Chung used OneGuide to accurately place 4 implants in the mandible. The question, compared to guided surgery, in the premolar area, the flap can be raised by checking mental foramen. It would be safer clinically to place implants. So at the end,
the accuracy of OneGuide and opening mental foramen, what do you think is more ideal? In the morning, as Professor Park mentioned about stabilization of guide, I really found the lecture really interesting. In this case, actually, I wanted to focus on stabilization, and in mental foramen space, there was residual bone. And I'm sure you'll come across frequently and clinically if there's a really resorbed bone. In the case where stability cannot be secured, and if the patient wants fixed restoration, in my case, I will not do guided surgery, because guided surgery is to allow me to place an implant in the desired position. In this case, you need to open flap. And in the lower anterior area, it can go to the lingual side, leading to vascular bleeding, and in most cases, the patients are older. When you can secure the stability of guide, you need to use if there is a slope, you need to flatten the bone. Through this question, I wanted to say that all on X cases, personally, I use OneGuide because I wanted to emphasize some benefits of OneGuide. Can I have some time to explain about the benefits of OneGuide? Can you pull up the slide? Can we pull up the slide? In my opinion, OneGuide surgery for all on X. First of all, X positioning is possible. When you do all on X, so when you open flap and do surgery in analog ways, you need to think about the bleeding and angle in the lower anterior as well as mental foramen. Because of these concerns, even if you use tilted implant, 30 degrees, 17 degrees, it's not easy to get that. Immediate loading period and osseointegration period. After that, at times the angle may be wrong. In this case, the implant was placed nicely. However, if the angle is not right, you need to make a plastic cylinder and you need to do wax up. Customized abutment needs to be fabricated in this way, and then it needs to be transferred to final prosthesis. All on four in itself is that It's a one-unit prosthesis. At lab, the loss of zirconia disc is quite severe. Because of these processes, the lab process, the ease of fabrication is not really good. What is the benefit of OneGuide? As you can see, in the case of anterior and posterior implant, you can place it as planned. In the case of anterior, the angle of anterior and posterior implant, the angle of tilted implant in the posterior can be adjusted. This is a similar case. On top of that, you can use Implant Studio program to twist the implant and change the hex. In the first try, more so than thought, the tie base 5 degree, it did not, the angle was slightly deviated, so it did not go in properly, so I adjusted the angle, and in my second try, as you can see, the angle becomes aligned fully. As you can see, OneGuide surgery can be used to place a tilted implant, and with this, you need to use customized abutment as well as tie base. You can use it for final restoration. Tie base is in the library, so you can fully use digital technology in the lab process as well. In the case where I did live surgery, tie base of tilted implant is here. The hex angle, if you do positioning better, it becomes aligned like this. As shown in the surgery, temporary prosthesis can be connected nicely. That's my impression based on my experience. This is AP spread. We need to utilize cantilever to somewhat degree. When you do surgery analog ways, it is difficult to measure using ruler, but when you do digital dentistry, you can look at the different measurements. AP spread and cantilever length leads to, we can assume how much stress is applied to screws. As Dr. Paez mentioned, within the same coordinates, you can make a design, so you know what is going to be like on top of your implant. In terms of prosthesis design, you can be more flexible.
Lastly, complication management. In this area, Paramaldo is famous. So according to his report, the complications are reported, various complications, dehiscence, fenestration, periodizese, and the various complications are reported. So you need to use the guide after stabilizing the guide to prevent the unexpected complications. So I use Osstem OneGuide system for all on X. Thank you for the presentation. As you said, in Korea, all on X is controversial, but using a case similar to this, I think you gave us very good explanation. And let's go to one more question. If the panorama is ready, let us know. I think this was raised as an issue from the Prosthodontics Academy. After final prosthesis is delivered, if it is a hybrid prosthesis, the patient can complain food retention. What do you think? So self-cleansing is very important for the longevity of the treatment. So aesthetics is important, but just like during the brain-emerg age, self-cleansing should be considered. And we need to train the patient on self-cleaning. So superfluous needs to be inserted. to the area for cleaning. That's very important. And the food retention can occur in the inside of the bone. So if there is a big step, it cannot be avoidable. So contour of the prosthesis is not just made out of glue. I use the distal denture. Here in this case, the treatment denture and the volume should be transferred to the final prosthesis. So in the process, if the gap is too big and if the patient wants a lip support, full denture for maxilla and fixed all-on 4 in the mandible would be appropriate. So lip support and the cleansability can be enabled. So that should be considered during diagnostic phase. Panorama image is available after surgery. So can we see it? Post-op panorama. What do you think? Actually, the surgery was finished successfully, but it was not done all by me. All-on 4 is not a routine procedure in Korea. I have done about a dozen of them. So the temporary hex positioning and all the processes have been made enabled thanks to the members of the R&D Center, especially Jonghyun Park, Dr. Jonghyun Park, or Dr. Cho or Dr. Kyungwon Kim. And thanks to them, I was able to do the surgery. I just implemented the surgery based on their protocol. Panorama looks good. So through this, actually, I am given the chance to do a lecture by Osstem through analog approach, but using the digital dentistry, the predictability and completeness of the treatment would be improved. So using the digital dentistry system, more challenging cases can be tackled with a digital approach. As Dr. Chung said, that was a very good live surgery, and I believe Dr. Jung has prepared for the live surgery thoroughly, and with the help of or with the support of all